So think about the last time you sent a text message with, like, a catastrophic typo.
Oh, I've had a few of those.
Right. The kind that completely changes the meaning of the entire sentence.
Yeah, it's always the worst.
It is. And maybe it causes, a brief moment of panic or some weird misunderstanding. But ultimately, you just send an asterisk, you correct the word, and it's just a fleeting error.
Right, you move on.
Exactly. But now I want you to imagine a typo that isn't on a screen, but is actually in your DNA.
Wow, yeah, that is a whole different scale.
Right. Just a single microscopic letter out of place in a genetic code that is, it's billions of letters long.
Billions,
Yeah.
yeah.
So the question is, how much chaos could one single typo actually cause? What if I told you that a misplaced genetic letter didn't just change the life of the person carrying it, but fundamentally altered, like, the entire course of human evolution?
It's pretty wild to think about.
It rewrote medical history. And, right now it's dictating the future of billion-dollar gene editing.
Yeah, I mean, it sounds almost like science fiction when you frame it that way, yet we are looking at the realities of a single base pair mutation here.
Right.
And if we connect this to the bigger picture, sickle cell disease isn't just another medical condition on a list. It is the original textbook case of what we call a molecular disease.
The very first one.
Exactly.
Yeah.
By understanding how sickle cell works, you're essentially looking at the foundational blueprint of molecular genetics itself. I mean, it literally taught science how to read illness at the level of atoms.
And that is exactly what today's deep dive is about. We are diving straight into that blueprint.
I'm ready.
We are pulling together clinical history, molecular biology, and evolutionary genetics to figure out exactly what happens when our red blood cells deform.
It's a fascinating mechanism.
We want to understand the mechanics of this, the human cost, and, the cutting-edge science trying to fix it. But to really appreciate that biological typo, we have to look at how it was discovered.
Because the timeline is completely backward, right?
Totally backward. We knew what the disease looked like in humans long, long before we had any idea what caused it.
Yeah, so the official Western medical discovery took place in Chicago in 1910.
Okay.
There was a cardiologist named Dr. James B. Herrick and his resident, Ernest Irons. And they were examining a 20-year-old dental student from Grenada.
His name was Walter Clement Noel, right?
That's the one. And he was suffering from severe anemia, jaundice, and these terrible recurring episodes of pain.
And Irons actually took a smear of Noel's blood, he put it under a microscope, and saw something completely bizarre.
Right, because instead of the normal red blood cells.
Yeah, the plump donut-shaped ones we all learn about in biology class.
Exactly. Instead of those, he saw these elongated, really stiff-looking crescent shapes.
Like they literally looked like the curved blade of a farm sickle.
Yeah, hence the name. And he sketched them out on the spot. Those 1910 drawings were so accurate that they still show up in hematology textbooks today.
Which is amazing. But we should probably be very clear here that 1910 is simply when Western medicine put a microscope to the condition and gave it an English name.
Yes, absolutely. That is a crucial distinction. The disease itself was recognized and understood in other parts of the world long before Chicago.
Yeah, I was reading through the sources on West African oral traditions, and the clinical descriptions of this disease have been present there for centuries.
Centuries, yeah. They have very specific names for it.
Like Ogbonje or Abiku in Nigeria.
Mhm.
And those terms describe children who were believed to be repeatedly dying and being reborn.
Right, it's a cultural framework trying to explain the incredibly high childhood mortality rate in those communities.
Which we now know was caused by the severe form of this exact disease.
Exactly. But the scientific leap to actually understanding the mechanics behind those childhood deaths and the reason Walter Clement Noel's cells look like sickles, it required decades of just waiting for technology to catch up.
Oh, for sure.
So in 1949, the famous chemist Linus Pauling ran an experiment using electrophoresis.
Yep.
He essentially used an electrical field to separate molecules based on their electrical charge and their size.
Okay, I have to pause here because this is just wild to think about. We struggle to get Bluetooth to connect sometimes, and in 1949, Pauling is using electrical currents to prove that a specific disease was caused by a broken protein.
It really was revolutionary.
Not a germ, not a visible structural defect, but a microscopic molecule.
Yeah, and he discovered that the hemoglobin from sickle cell patients physically moved differently across the gel than normal hemoglobin. And that finding is why Pauling coined the term molecular disease.
The first of its kind.
Right, but the true breakthrough arrived a few years later, between 1956 and 57. A British biochemist named Bernard Ingram used this highly specialized technique called peptide fingerprinting.
To find the actual typo.
Exactly. He wanted to find the exact location where the abnormal hemoglobin differed from the normal kind, and he found a single amino acid substitution. Just one.
Wait, just one.
Just one out of 146 in the beta chain of the protein.
Let's pause on that scale for a second. That is like finding a single misspelled word in a complete multi-volume encyclopedia.
It's finding a needle in a haystack of beetles.
Right. And Ingram accomplished this years before Watson and Crick even fully popularized the double helix structure of DNA.
Yeah, he basically proved that a single point mutation at the molecular level could cascade into a devastating human disease.
Okay, let's unpack this cascade, because it's not just a matter of a letter changing, right? What exactly is that misspelled word doing to the body?
So it starts with one DNA letter in the HBB gene. The healthy sequence should read GAG, but it mutates to read GTG.
Just an A to a T.
Just an A to a T. But that tiny swap instructs the cell to remove an amino acid called glutamic acid and insert one called valine in its place.
Okay, well, and why does that matter so much?
Well, glutamic acid is hydrophilic, meaning it loves water. It carries a negative charge, and it interacts easily with the watery environment of your blood.
Got it.
Valine, on the other hand, is hydrophobic. It literally repels water. It is the nonpolar, oily molecule.
So by placing a water-hating, oily molecule on the outside of a protein that literally lives and floats in the watery plasma of our blood, you create a massive physical problem.
A huge problem, yeah.
The analogy that really clicked for me in the sources involves engine parts. So imagine you have a smooth, perfectly lubricated metal piston inside an engine, right?
Right.
It's designed to slide past other parts without any friction. That's your normal hemoglobin. But this genetic mutation takes a tiny spot on that smooth metal and replaces it with a strip of heavy-duty, double-sided industrial tape.
That sticky patch of valine is the perfect way to visualize it, because here is the crucial mechanism. This stickiness only activates under specific physiological conditions.
Wait, really? It's not always sticky?
Nope. When this abnormal hemoglobin, which science calls HbS, is holding onto an oxygen molecule, it's totally fine. The physical shape of the oxygenated protein actually hides the sticky patch inside its fold.
Oh, wow, so it's concealed.
Exactly. But as the red blood cell travels through the body and delivers that oxygen to your tissues, the hemoglobin molecule shifts its physical shape.
Because it dropped off the payload.
Right. And suddenly that sticky patch is exposed to the outside environment.
And that double-sided tape is suddenly grabbing onto whatever it can find.
Precisely. The sticky patch on one hemoglobin molecule binds directly to a matching pocket on a neighboring hemoglobin molecule. Then another binds to that one. They literally daisy-chain together.
Oh, I see.
In a matter of milliseconds, they polymerize into these long, rigid, rod-like fibers. Imagine thousands of these stiff fibers forming inside the red blood cell.
Like tentpoles.
Yes, they act exactly like tentpoles, physically stretching and distorting the flexible, circular red blood cell from the inside out, forcing it to warp into that stiff, crescent sickle shape.
Just the cascading physical reaction to one wrong amino acid. That is wild. But, I mean, a cell changing from a circle to a crescent sounds almost trivial. Like, how does that shape change translate into such a brutal disease for the patient?
Well, it comes down to two very distinct, highly destructive disease processes that happen immediately downstream of that shape change. First, you have hemolysis.
Which is the destruction of the blood cells, right?
Yes. Normal red blood cells are incredibly flexible. They can squeeze through the tiniest microscopic capillaries in your fingertips or your brain and just bounce back to their normal donut shape.
And they usually live for a few months, right?
Typically about 120 days. But sickled cells are stiff, brittle, and structurally compromised. Your body recognizes they are damaged and destroys them prematurely, or they just physically shatter while they're circulating.
And the sources say they only survive for like 10 to 20 days.
Exactly. And your bone marrow simply cannot manufacture new red blood cells fast enough to replace the ones that are constantly dying.
So you're always running at a deficit.
Right. That deficit results in severe chronic anemia. The patient's tissues are perpetually starved of oxygen because the delivery vehicles are literally being destroyed in transit.
Man. And the second process feels even more visceral when you read about it. Vaso-occlusion.
Yeah, that's the pain component.
Because these sickled cells are stiff and they're covered in those sticky proteins, they don't flow smoothly through the blood vessels anymore. They snag on the vessel walls.
Right, they adhere to white blood cells.
And they create microscopic traffic jams in your circulatory system, completely blocking the flow of fresh blood to whatever tissue is downstream of the blockage.
And that blockage leads to what clinicians call a vaso-occlusive crisis. The tissue downstream of the traffic jam is actively suffocating.
Which causes the pain.
Agonizing pain.
Right.
Repeated ischemia, this lack of blood flow, systematically destroys organs over time. A very concrete example of this cumulative damage is a process called autosplenectomy.
Which I read happens incredibly early in life for these patients.
Yes, in young children with the severe form of the disease, the spleen, which normally acts as a crucial filter for your blood, gets repeatedly clogged with these rigid sickled cells.
So it's just starving itself of oxygen.
Exactly. The spleen's own tissue dies from lack of oxygen. By early childhood, the organ effectively shrivels up and destroys itself.
That's terrifying.
It is, especially because the spleen is vital for fighting off specific types of encapsulated bacteria, like the ones that cause severe pneumonia. Without a functioning spleen, these young children face a dramatically elevated risk of overwhelming, often fatal bacterial sepsis.
But this specific mechanism is actually where we see one of the biggest public health victories in the timeline, isn't it?
It is, yeah.
Because clinicians realized the spleens were failing long before they mapped the whole molecular tape analogy we talked about, and that led to a massive breakthrough in pediatric care.
Right. In 1986, a landmark randomized trial proved a remarkably simple intervention. If you give these infants prophylactic daily doses of penicillin starting right at birth, you can cut life-threatening pneumococcal infections by an astounding 84%.
84%, just from basic penicillin.
Just penicillin. That single clinical insight is the entire reason why universal newborn screening for sickle cell exists across the U.S. and many other nations today.
So you identify the typo at birth, you start the penicillin, and you prevent the child from dying of an infection at age 2.
Exactly.
Okay, I want to clarify something here, because going into this deep dive, I definitely held a major misconception.
Oh, really?
Yeah. I always assumed the disease was basically dormant, and it only caused damage during one of those sudden pain crises. Like, you're completely fine, and then you have a crisis, and then you recover, and you're fine again.
You are definitely not alone in that. That is one of those common misunderstandings, even among healthcare workers.
Wait, really?
Oh, absolutely.
Yeah.
While the acute pain crises are the most visible and, terrifying symptom, the hemolysis, the continuous shattering of the red cells, and the low-grade microscopic vessel blockages are happening constantly in the background.
So the damage never really stops.
Oh, no, it doesn't. It is causing cumulative, silent damage to the kidneys, the retinas, the bones, and the lungs every single day of the patient's life, even on days when they report feeling relatively well.
Okay, wait, I need to stop you there, because this makes absolutely zero evolutionary sense to me.
Okay.
Well, if this mutation is so violently destructive to the human body, it's destroying organs, causing lethal infections in childhood before a person can even reproduce. Standard Darwinian logic dictates that natural selection should have wiped this gene out thousands of years ago.
That is the logical assumption, yes.
How is a deadly genetic typo still surviving in the human population?
To resolve that paradox, we actually have to look at a concept in evolutionary biology called balanced polymorphism.
Okay.
In the early 1950s, a geneticist named J.B.S. Haldane proposed a seemingly radical idea. He suggested that a deadly genetic disease could persist at high frequencies in a population if and only if carrying just one copy of the mutated gene gave the carrier a significant survival advantage against some other deadly threat.
Oh, so it's the ultimate biological trade-off.
Exactly. And field studies by A.C. Allison in East Africa in the mid-1950s proved Haldane's theory. They found that if a person had one normal hemoglobin gene and one sickle hemoglobin gene, a state we call sickle cell trait, they were significantly less likely to die from severe Plasmodium falciparum malaria.
But how does one mutated gene stop a whole parasite? I saw the sources mention it alters the environment of the cell itself.
Right, so when the malaria parasite infects a red blood cell, it consumes massive amounts of oxygen to replicate.
Okay.
In a person with sickle cell trait, that sudden drop in oxygen triggers the abnormal hemoglobin to polymerize and sickle the cell.
Yeah.
The spleen recognizes this warped infected cell and just destroys it
Yeah.
before the malaria parasite has a chance to fully replicate and overwhelm the body.
Oh, wow. So if you inherit two normal genes, you are at high risk of dying from malaria.
Yes.
If you inherit two sickle genes, you have sickle cell disease and face all the devastating complications we just discussed.
Right.
But if you inherit one of each, the trait, you get a protective shield against malaria without triggering the severe everyday symptoms of the disease.
Exactly. That precise mathematical balance is why this specific gene mutation is found at incredibly high frequencies, up to 10 to 25% of the population, in historically malaria-endemic regions.
Like sub-Saharan Africa.
Sub-Saharan Africa, parts of India, the Mediterranean, and the Middle East. It is one of the most perfectly documented examples of natural selection acting on humans. The environment, in this case malaria, exerted such intense evolutionary pressure that it essentially forced this genetic compromise.
Which brings up a huge debate in the medical community about the trait itself.
Yeah.
Because for my entire life, I was told sickle cell trait was totally harmless.
That's what a lot of people were taught.
Just a biological quirk. You're a carrier, you're immune to malaria, you go about your life. End of story.
What's fascinating here is how the medical consensus on that exact point has completely fractured over the last decade. For a long time, the dogma was exactly what you just described, that the trait is universally benign. But the epidemiological data is increasingly telling a very different story.
So the line between the harmless trait and the full-blown disease is getting blurry.
Very blurry. We now know that people with the trait usually produce enough normal hemoglobin to dilute the sticky sickle hemoglobin, which prevents those rigid tent poles from forming.
Okay, so most of the time they're fine.
Most of the time. However, under extreme physiological stress like severe dehydration, very high altitude, or intense, pushing past your limits physical exertion, that delicate chemical balance inside the cell can tip. The cells can suddenly sickle.
Which explains the tragedies we've seen in athletics.
Yes. Over the past 20 years, studies have linked sickle trait to an elevated risk of exertional rhabdomyolysis, which is a rapid, highly dangerous breakdown of muscle tissue and exercise-related sudden death.
Oh, man.
A deeply concerning cluster of deaths among U.S. college and NFL athletes who carried the trait actually drove the NCAA to mandate sickle cell screening for all athletes after 2010.
And it's not just isolated to extreme sports, right? The sources mention a link to a rare, highly aggressive kidney cancer called renal medullary carcinoma.
Yes, and that cancer occurs almost exclusively in people with sickle cell trait. So defining where the disease ends and the quote-unquote harmless trait begins is an incredibly active area of debate among hematologists today.
And, you know, that transition from pure biology to societal impact is where the story of sickle cell becomes deeply troubling, because historically, society has severely mishandled the science of the trait.
Without a doubt. They've often wielded it against the very people it affects.
The military and athletic screening controversies of the 1970s are a glaring example of this mishandling. When sickle trait testing first became widely available, several U.S. states passed mandatory screening laws.
Right.
But looking at the historical records impartially, the information wasn't used to counsel or help people at all. Some employers and insurance companies used trait status to actively restrict perfectly healthy people from getting jobs or coverage.
The Air Force Academy barred trait carriers from pilot training for a significant period. And this was based on totally unfounded theoretical fears about how their blood would react to high altitude in unpressurized cabins, despite these individuals being completely clinically healthy.
I even read there were state bills proposed at the time that would have required mandatory screening before issuing marriage licenses.
Yeah, it's genetic discrimination, plain and simple.
And it's clear this caused immense damage to public trust, because this was happening in the early 1970s, right around the time the Tuskegee syphilis study revelations broke.
The timing was disastrous.
You had government public health programs demanding blood from Black citizens for genetic screening without providing adequate medical counseling or even passing basic anti-discrimination laws.
And the resulting backlash was massive, as you'd expect. It completely shattered trust between Black communities and public health genetics programs for a generation.
It's hard to blame them.
Exactly. If there is a silver lining to be found in that era, it's that this specific disaster forced the creation of the strong privacy and informed consent safeguards that govern modern newborn and genetic screening today. The medical establishment learned a very hard lesson in how not to conduct genetic public health.
But systemic failures aren't neatly contained in the past, right?
Definitely not.
The sources outline two major ongoing clinical inequities happening right now in modern hospitals. And the first one is pain management bias.
Right. Remember that the hallmark of sickle cell disease is the vaso-occlusive pain crisis. The challenge for doctors is that there isn't a simple thermometer or blood test that flashes a red light and says, yes, this person is in agonizing pain. Diagnosis and treatment rely entirely on the patient verbally reporting their pain level to the physician.
And because the U.S. sickle cell population is overwhelmingly Black, which, as we discussed, is a direct legacy of the malaria geography combined with the transatlantic slave trade, these patients face documented systemic bias when they go to the emergency room seeking help.
Yes, multiple peer-reviewed studies, including audits of emergency department wait times and opioid prescribing patterns, show a clear, persistent disparity.
It's awful.
Patients with sickle cell in a pain crisis consistently wait significantly longer to receive pain medication. They receive lower clinical doses, and they're far more likely to be suspected of drug-seeking behavior compared to patients presenting with other severe pain conditions like, say, kidney stones or fractures.
It has basically become a central, glaring case study in how implicit bias actively alters medical treatment. And it's maddening to read about this pain bias when we actually have a chemical tool to stop the sickling in the first place.
You're talking about hydroxyurea.
Yeah, I was reading about it in the notes. Hydroxyurea is a daily oral medication that was proven in a pivotal 1995 trial to cut the frequency of pain crises by roughly half.
It is highly effective and widely considered the standard of care. Yet, the data consistently shows it is dramatically underprescribed across the patient population.
But how does a pill actually stop the double-sided tape from sticking? And honestly, why wouldn't every single patient be on it?
Well, hydroxyurea works through a truly fascinating mechanism. It essentially tricks the patient's bone marrow into producing fetal hemoglobin, or HbF.
Like baby hemoglobin.
Exactly, the type of oxygen-carrying protein we all make while in the womb. Crucially, fetal hemoglobin does not have the mutation. Doesn't have the sticky valine patch, meaning it cannot polymerize. So by increasing the amount of fetal hemoglobin in the blood, hydroxyurea dilutes the sickled hemoglobin and prevents those rigid tent poles from forming.
That's brilliant. So why the underuse?
It's a complex mix. You have physician unfamiliarity with dosing guidelines, fragmented access to hematology specialists for adults, and significant patient distrust. Plus, hydroxyurea actually originated as a chemotherapy agent, so it carries a stigma.
Ah, I see. But I saw that fetal hemoglobin detail in the notes, and it blew my mind because that exact mechanism tees up the biggest breakthrough in this entire story.
The gene editing.
Yes. In December of 2023, the FDA approved Casgevy, or Exascel. This is the first CRISPR-Cas9 gene editing therapy ever approved for human use. And they aren't even fixing the typo, right?
Nope, they aren't.
They're basically using a genetic cheat code to revert the body back to its factory settings. Talk me through how that fetal hemoglobin switch works with CRISPR.
It is an incredibly elegant biological workaround.
Right.
So, as we noted, infants with sickle cell don't have symptoms for the first few months of life because they were still relying on their fetal hemoglobin.
Right.
But shortly after birth, our bodies naturally activate a gene called BCL11A. Think of BCL11A as a biological switch that permanently turns off fetal hemoglobin production and turns on adult hemoglobin production.
But in these patients, that adult hemoglobin is the mutated sticky version.
Exactly. So instead of trying to locate and repair the tiny single-letter mutation in the adult hemoglobin gene, scientists use CRISPR to edit the patient's own stem cells. They specifically target and cut the enhancer region of that BCL11A gene.
So they just break the off switch.
Exactly. By breaking that switch, they permanently prevent the body from turning off fetal hemoglobin.
That is so smart.
The stem cells are returned to the patient, the body resumes churning out massive amounts of healthy, non-sticky fetal hemoglobin, and the disease is essentially stopped in its tracks. In the clinical trials, the vast majority of patients were completely free of severe pain crises for over a year.
It's essentially a cure. I mean, we went from Linus Pauling observing electricity-moving blobs on a gel in 1949 to Vernon Ingram finding the exact misspelled letter out of 146 in 1956 to literally sending microscopic scissors into the nucleus of a cell to snip a specific gene enhancer and bypass the typo entirely.
It is a profound scientific triumph, one that proves the true potential of gene editing. This raises an important question, however, one that brings us right back to the systemic issues we just unpacked.
Hello, the cost.
Yes. The list price for this single CRISPR therapy is over $2 million per patient.
$2 million for one treatment.
$2 million. And furthermore, the procedure requires intensive chemotherapy-like conditioning to wipe out the patient's existing bone marrow before the edited stem cells can be transplanted back in.
Wow, so it's not just an injection, it's a massive medical undertaking.
A huge one. So you have an incredibly complex, multi-million-dollar cure for a disease where the absolute highest burden of suffering and mortality is located in low-resource African health systems.
Systems that are the least equipped to afford the drug or administer that complex bone marrow transplant process.
Exactly.
It's the ultimate modern paradox. We have achieved the pinnacle of molecular medicine. We can literally edit the code of life to cure a devastating disease, but it's currently completely out of reach for the vast majority of the hundreds of thousands of people born with this condition globally every single year.
It really forces society to confront what the ultimate goal of modern medicine actually is. Is it simply to achieve an isolated technological marvel in a specialized lab, or is it to deliver tangible health equity across the globe? Sickle cell disease is positioned right at the bleeding edge of that debate.
We've traced an unbelievable scientific arc today. We started with a single sticky amino acid, that microscopic piece of double-sided tape, and followed it through its role as a survival mechanism against malaria into a 1950s molecular breakthrough, all the way to a modern $2 million CRISPR cure.
And for you listening, it's vital to remember that understanding sickle cell isn't just about absorbing obscure medical trivia. It is a condition heavily prevalent worldwide, and it is a standard part of routine newborn screening in many countries.
Right.
The evolutionary story of sickle cell is actively playing out in our human population right now. It represents the absolute frontier of both evolutionary science and the ongoing fight for medical equity.
Absolutely. We opened the show by thinking about the chaos a single typo in our DNA can cause. But the story of the sickle cell trait, how it was widely considered a completely harmless genetic curiosity for decades until extreme physiological stress revealed its hidden lethal risks, really makes you wonder.
Oh, definitely.
What other supposedly benign genetic quirks are you and I carrying around inside our cells right now, just waiting for the exact right environmental trigger to reveal their true nature?